Good morning, afternoon, or evening to everyone, depending on where you are around the world watching our webinar today. We'll just give people a few minutes to pop in. I notice the attendees are starting to jump up. But looking forward to our last webinar for 2022 in our research component, and we are then hopefully all looking forward to a great break as we come back in 2023 for what looks like it's going to be a fairly busy year. Okay, so I'll just kick off with some introductions. So welcome everyone. As I said, my name is Dr. George Margellis. I'm the independent chair of the Aged Care Industry Information Technology Council, and I will be a facilitator for today's events. Welcome to the Aged Care Industry Information Technology Council research webinar, focusing on improving aged care through consumer-driven health services and informatics research. From this point forward, I will refer to our organisation as the Council. Today's webinar is part of our monthly research webinars hosted by the Council. Before we start, I'd like to acknowledge the traditional owners and their custodianship of the land in which we meet. We pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australia and global society. A couple of housekeeping items before we kick off. All your microphones have been muted. If you have any questions during the event, please post them by clicking on the little Q&A icon on the bottom of your screen and entering the question into the screen panel. You can ask the questions either by identifying yourself or anonymously. You have that option. The session today is being recorded and will be made available in the next few days. So if you have any friends or colleagues who would have liked to attend, but because of the various clashes occurring so close to Christmas can't be here, well, here's a great way to spend some time over the Christmas holidays watching this webinar. If you have any technical issues during the webinar, please again just use the Q&A panel to raise those questions with the team, and the group in the background will do their best to get you back up and running as soon as possible. Today's research webinar, titled Towards an Informative Powered Learning Health System, will be presented by the University of Melbourne Professor Wendy Chapman and Dr. Kit Huckvale. Professor Wendy Chapman is the Associate Dean of Digital Health and Informatics at the University of Melbourne. She also directs the Centre for Digital Transformation of Health. Her research aims to leverage data and digital technology to transform healthcare delivery. She is a leading researcher in digitally enabled new models of care in an end-to-end pipeline to design, implement and deliver innovation in the Australian health context. I've had the pleasure of knowing Wendy for a number of years now since she's arrived here in Australia. Dr. Kit Huckvale is a research fellow at the Centre for Digital Transformation of Health and leads development of the Validitron Sandbox, a new platform for testing digital health apps with electronic medical records and other clinical software in a personal virtual sandbox. Originally trained as a medic, his work in digital health focuses on the design, quality and safety of mobile consumer-facing health technologies such as smartphone apps and the development of platforms to support research and innovation. I welcome Professor Chapman and Dr. Huckvale to share their screen and commence their presentation.
Excellent, thank you. Want to check, make sure you can hear me?
Good.
All right.
All good.
Okay, happy to be here. Thanks so much. So we know in aged care that there's really, maybe next slide, Kit, an imperative to use data and technology to really help transform how we're caring for and partnering with aged care people. We also know there are hundreds, thousands of apps, information systems, and tools that we could be using, but there's very limited adoption. And there are many different reasons for that. Next slide. But as we think about how to really begin benefiting from the data that we're collecting and using the most modern technology to help deliver the best care, the model that we are following is the learning health system model. And what's appealing about this model is that it's driving improvement by learning from routine care. It's not research on the side that's separate, that's generating papers. It's not technology for technology's sake. It's really, how do we, leverage data that we have, and, create the data, collect it, link it so that it's ready to analyze, gain insight from that data that is relevant for our practice and for our, the health, improving the health of our patients and clients, developing solutions that might address the problems that we identify through the data, making those solutions actionable and shareable and delivered at the point of care, and then generating data from those new solutions that we put in place and capturing that data so that we again enter this cycle and learn from what we're doing and drive practice change. And there, just so you know, there is a bit of a lag in my internet. So, so I really like this quote from Robert Wachter from the book, The Digital Doctor, which I would highly recommend. And I think this would resonate with people, that the fact that you introduce computers into healthcare doesn't just replace, handwriting with a new font. Instead, the computers and the tools transform the work, the people who do it, and their relationships with one another and with patients. And because of that, there are many unknowns about how to best leverage data and technology in patient care. And that is why I would represent my vision of a information or informatics powered learning health system with this formula that I'll attribute to Chuck Friedman. And it was enhanced by somebody else to say that, the human by itself, if you add the computer or data or technology to it, then that's better than the human. But also we need to be using the scientific method to really learn from what we're doing and provide feedback and see if what we're doing is making a difference. And that is how I would describe an information or informatics powered learning health system. It's our vision to leverage this framework of learning health systems and to create innovation hubs that are working within different healthcare sectors in Victoria and beyond, but starting with Victoria because that's where we have more reach and partnerships. And this would be the idea about having, partnerships between the healthcare delivery organization, the community organizations, the patients and their carers, this partnership to really test and evaluate new models of care, new ways of working, new devices in rapid cycles of continuous improvement. So it's not research for research's sake, but it's also not quality improvement that never gets measured. It needs to be much more iterative and fast, and we need to be learning as we go. And so if we're able to develop these hubs where there are these true partnerships and we're embedded in the delivery of care for the patient, then we can improve the way that we make decisions about which technologies work and to adopt in which settings, to customize the technologies. There's a lot of technology out there that's already, off the shelf, as they tell us, but we know that when you put them into your own environment, there are all kinds of customizations that have to happen to account for the workflows, account for the culture and the types of data that we have available, to generate evidence for their effectiveness and to understand when they work and where they don't work, to monitor their performance because they'll change over time as people change and as data sources change, and the world changes, and to be able to scale them beyond the single sites that we start with. And in the long run, to really have some kind of a mark of certification for the industry of different technology platforms that are appropriate and evidence-based for aged care. That's our vision in this ecosystem. If we think about the learning healthcare system framework, and we've got data to knowledge, and that's a really hard nut to crack. We're going to focus today on the knowledge to practice part. And that's based on the idea that when you develop a drug or vaccine, it's a very clear pipeline. Everyone knows what to do, what to ask, and what order to do it in. But for digital health innovations, it's a big black box. There's a big gap in implementing and evaluating digital health innovations, and it's much too slow. So we are operating in that space to try to help delineate what those steps might be and develop infrastructure and resources and processes to step through that dark matter area that we don't have a lot of knowledge about how to do in a way that we learn from and refine and improve over time. So we're going to talk about a case study and an example of remote monitoring and telehealth as it may be applied in aged care, using some resources that we've developed called the Digital Health Validitron. And I will turn it over to Kit, who leads the Validitron.
Thank you, Wendy, and hello, everyone. So yeah, as Wendy said, we want to share a little bit of what we're doing in the Validitron. This is still fairly early days for us, but there are two key resources that we're building out that we think might be useful to support the development of digital health innovations, particularly with a focus on, what are the barriers, what are the challenges that people experience that mean that perhaps when innovations get out there into the real world, they don't necessarily perform as people were hoping or as expected. And what can you do about anticipating those potential challenges when you still have time and resources to do something about it, i.e. during the development process? So we're going to talk about two things, the Validitron Sim Lab and the Validitron Sandbox, and as Wendy said, how they might be applied to support an illustrative project in aged care around telehealth. So the research question we're interested in today is around remote monitoring. And the specific question is, how could remote self-monitoring data, so data being collected by patients, support communication and decision-making in the context of a telehealth consultation amongst older community-dwelling adults? And I guess for the purposes of our discussion, how could something like simulation using the kind of tools that the Validitron offers help? And this project actually came out of a real collaboration between our centre and the Northern Hospital. And that collaboration was responding to their virtual emergency department initiative that was set up in COVID. And they got to a stage where they wanted to review the progress they've made and explore potential ideas about where to go next. And one of the topical issues that came up was, during COVID management, they'd been giving out pulse oximeters and other devices to patients who are community dwelling patients with COVID, so not necessarily severe enough to need to be admitted. But they were then having to follow up those patients and potentially not necessarily have easy access to the data those patients were collecting about their health status. And I think, that specific use case mirrors other examples we might see, particularly those relevant to those older adults living in the community, for example, those with long-term conditions like respiratory disorders and diabetes. So I think, that they felt and we felt that there was a broader use case around how you can create value from the tools that patients are increasingly using in their everyday lives to monitor their conditions, and how can that be used to support clinical decision making. So in that context, I think there are some things that I think are fairly either easy to establish or well understood by the teams who are initiating these projects. So for example, in this case, the clinical use case was well understood. We were able to sit down and work out with our clinical colleagues fairly early on what a representative user might look like. For example, someone with COPD who had a history of exacerbations, where there was a well-established management plan, but there was still a requirement to be able to identify deterioration and respond appropriately. And I think connected to that, there were also other things that were well-defined. So for example, that there was already an established data collection platform that was of interest. So it was a mobile app connecting via Bluetooth to a pulse oximeter and potentially other devices. And from the team as well, kind of as a catalyst for this project, there was some vision that they wanted to achieve a technical integration. They'd invested all of this effort in making the virtual ED service work around a telehealth client from Health Direct. And they recognized early that, getting a streamlined experience from a clinical management point of view and also an administrative point of view was going to be important. So there was some vision for technical integration that was driving this project. But going back to, what does the Validitron exist for? I think the team also recognized early that there would be some challenges around this. There might be lots of different ways to realize this idea of technical integration. Is it something that integrates with the EMR? Is it something that needs to sit with a telehealth experience? And alongside each of those options, there might be very legitimate user acceptability and feasibility concerns, as well as broader workflow concerns. And I think one of the things we're very interested in the Validitron is the fact that digital health innovations never exist in isolation. They always must work in the context of existing human workflows in physical spaces with all the pressures and constraints that there are there, but also increasingly with digital workflow. So there are other tools that new products need to sit alongside and work with. And so part of what we're trying to do in the Validitron is make it as easy as possible to unpack some of those issues, particularly early on in a project. So not just how does a tool work from a user acceptability point of view, but how might it work in context? And one of the things we recognize is that getting access to healthcare settings to do that can be quite challenging, particularly at the early stages of a project when you might not have a lot of things to show. And there are reasons for that, which are good reasons around governance, around pressures in clinical environments. So one of the things the Validitron is a physical environment where we can do that kind of prototyping and exploration work. And we have a co-design space where we can bring together different stakeholders to explore some of these issues and do that early ideation. But perhaps more interestingly for our discussion today, we also have a set of immersive simulation rooms where things like existing workflow and how users interact with technology can be explored in an immersive setting that is nevertheless not part of a real healthcare context. So you can set things up, test them out, demonstrate them even without having to worry about affecting, day-to-day care delivery. So we have a GP environment, we have a home environment that also doubles as a therapy space, and we also have a hospital single bed wardroom. And each of those spaces is connected to observation areas, so we can do more formal exploration of, for example, how users interact with technology. And all of this space is designed for digital health. So we, in addition to this physical environment, we have a virtual environment, which we call the Validitron Sandbox. And the aim of that is to make it really easy to set up and run those existing digital tools that you might encounter in those environments. And that comes back to this point about digital health tools never working in isolation. You want to be able to see how your new tool fits with existing tools. And so the sandbox and the concept of the sandbox is to make it easy to do that. So I'm going to step you through this use case around remote monitoring to show how we used the sandbox and also the sim lab in conjunction to enable some of the exploration in the context of that project. And the idea behind this is to be able to do it very easy and early, and really perhaps at the stage when you have nothing more than some wireframes or even a low fidelity prototype of the kind of thing you want to do. So if we go back to our self-monitoring example, through ideation, it became clear that fairly early on that the kind of thing we would be thinking about is some kind of portal view into the remote monitoring data that patients were collecting. And it was possible, for example, to map out what that might look like in terms of data representations. But of course, that representation has to sit within an existing context around things like the EMR. And so in this project, we were able to use the Validitron Sandbox to show what that prototype might look like if it was working inside the established EMR environment. And that simple act of being able to prototype allows early discussions about, well, for example, does that work in terms of the workflow in the EMR, or are the way things being presented incongruous in terms of how things are already presented in that context? Fairly simple things, but those are the kind of cumulative things that together can dictate whether a tool is well used or perhaps not used at all. So the sandbox makes it easy to put together infrastructure. So in this case, we have this low fidelity prototype, which you can see on the right, and we need some other ingredients to be able to set up a demo. We need an EMR. So for the purposes of what I'm going to show you today, I'm going to show you an open source EMR called OpenEMR, but the sandbox is designed to be able to host other EMRs, including commercial products. And we need a way of being able to show how that prototype would look like if it were a real running app. And the sandbox includes a tool that allows us to do just that. So to take that wireframe and make it something that's interactive inside the EMR. So we can deploy that in a few steps. It's a scripted process, and that then gives us a running EMR instance, which is set up with login. So I can then log in. I can create a patient in that, or we can pre-populate it with data. And we're using a standards-based extension mechanism called SMART, which is linked to the FHIR standard, which means it's easy to drop in new features like this remote monitoring portal. So we're using this idea of a prototyper, which allows us to display the wireframe. So we can then drop that wireframe into our EMR environment. And from there on, it just behaves as though it was a normal app behaving inside the EMR. And users can come and interact with that. We could run it, for example, in the sim lab, or we could show it up on the screen. And it just provides a little bit more context for people to be able to start providing concrete feedback about whether this idea has legs at all, or whether it needs to be reworked. And again, going back to kind of, the value of the Validitron, I think it's that, making things concrete and tangible, I think brings home and enriches the discussion in ways that, are not always appreciated. I think certainly I've been in discussions where very late in a project, there's a fundamental realization amongst some members of the team that what was being proposed is not what they thought. And I think this act of being able to show it aims to try and reduce that risk. And so, for example, in this project, we discovered early on that actually this displaying the information in the EMR probably wasn't going to be the right way to go. And actually, it'll be more useful to have it in the context of the telehealth environment instead. So we continued to work up the idea, and we got to the stage where we actually had a fully working interactive smart app. So real data that we could collect from a real patient and display in a portal in an update in real time. And I should say everything I'm showing you today is simulated patient data. And the sandbox again makes it easy to explore that. So we have a telehealth client, which mirrors some of the functionality you see in products like Health Direct. And we can set that up quickly. We can simulate a patient logging in and set up a call between a clinician and a patient. And that runs like a Zoom call, or as you'd expect. But the environment also includes the ability to display add-ins. And so we can drop that app prototype into the environment as an interactive add-in that the clinician can trigger in the call and view the data that the patient has collected, and or potentially request the patient to collect additional data while the call is running, and it will update in real time. Exploration, and that sort of, again, that surface area for prototyping and design allows other options to be explored quickly. So, for example, one of the requests that we identified fairly early was to be able to share that portal view back to the patient, so that there could be a discussion about what data had been collected and what the GP or the clinician might be seeing in terms of trends. So the telehealth client allows data to be shared back to the patient as well, and so they get a synchronized view.
Okay, so, and I am speaking on Kit's slides, so I won't be quite as articulate, but the Validitron then gives us this opportunity to have the digital part of the care that we're providing with the physical immersive in the sim lab, so that we can really work on, creating, co-designing and validating these workflows and new tools and interventions together with patients and clinicians. So doing this, we can now start to do usability studies, and we can look at, is it easy for the patient? Maybe this is a different patient. Is it easy for her to be able to measure her pulse ox, use the pulse oximeter and send the data to the clinician in real time? What's the usability of that? Do we have the font right? Do we have the colors right? Do they get confused? So, do they understand the visualization going, yes. So while we're, working with the patient on the interface, we can also be working with the GP in this case, or the ED doc in looking at that and carrying out the visit in a simulated way as if it was a real visit, and we can be recording it, we can view it from the one-way mirrors, and we can speak to them, through there if we want to change things. And not only, so now it's not just talking about or just looking at something, it's really watching what they do, because what people say is often different than what they actually do. So it gives us that power. Another advantage of the Validitron Sim Lab and Sandbox is not only for doing these kind of studies and designing new models of care and validating them, but really to be able to demonstrate and share what you're talking about. Because often when you describe to someone what you're thinking of doing, it's just not concrete enough to understand. And so having this way to demonstrate and get feedback in an early stage can be really powerful. And this is really useful potentially for vendors as well. Can you drop your tool into the existing ecosystem and digital environment and now show the aged care center or the hospital administrators what you're talking about how it would integrate. Or if you are developing something new and you have clients already, how do you show them, this new technology that they might be able to leverage when just describing it isn't good enough? So that's another thing that we can use the Validitron for. And I think a really powerful thing about this is rethinking the power and agency that the patient has in sharing their data and discussing their data. And so here in this telehealth visit with this, simulated patient, Frank, he can share his data that he's collected, and he chooses, are you going to share this with your clinician, and clicks on it. And all of a sudden the patient becomes the center. And you could imagine doing experiments with different types of governance, where if he is now linked to data from his GP, data from, different things that he's collected in the past, that he now has the opportunity to say, yes, do share this with the ED physician or not. And it's really up to that person, and you don't have to have those agreements across institutions. So it can open up new conversations about innovative models. And, things like the waiting room. We've learned from patients that the waiting room experience in telehealth can be very frustrating and discombobulating. And so, could we use that time to drop in different apps and have patients, look at their data before they visit with the clinician, organize the data and the questions that they have, fill out symptom or mental health screening or symptom surveys. How do we leverage that time? So it gives you the chance to start asking questions that you would just never ask in a real situation. Like, for example, the virtual ED, they're growing that statewide, and they just do not have time to be asking these kinds of questions about how to improve and create better integration. But with the Validitron, you can start to ask those questions in a really agile, quick way. So the Validitron is, the sandbox and the sim lab are a big part of the Validitron, but we also, we start with offering insights about, about the problems and questions that you want to address, and helping think through, is it a real problem? Is there data to support that problem? What do users want before you actually start the development? And then we've got the co-design space where you're really, working through what could it look like? What are the possibilities? The immersive simulation laboratory and the sandbox, that suite of tools. So if we're able to really pull all of this together and create these learning health system innovation hubs, you could really see that you can start to create kind of a tick. I think I can't remember. Well, I know, I'm sorry, they don't use this term in the US, but they use it here. A tick of approval, kind of a tick of approval of, you develop something and you can say, yes, this is interoperable with X and Y under these conditions. We've tested its usability. We have looked at health technology assessment. We've modeled different ways that it might be funded. And we've done that with the people who make the decisions about the funding, so that we are, from the beginning, designing in the aspects to measure the things that they want answered in order to determine whether it could be funded in that way. That it's been, validated for clinical and patient workflows, that it meets regulatory compliance, and that there's evidence of clinical outcomes in pilot studies, so that as you grow this innovation, you're doing it in a really methodical and data-driven way, and generating evidence that then helps you lead to that scalability that we have to have in order to really transform healthcare in aged care. Just a quick post note that we will be putting this into practice with an MRFF rural and regional translation grant that we received with Anna Peters at Deakin, doing virtual care for older adults in regional and rural areas. And the focus there will be remote monitoring. And so we'll be working over the next couple of years on that for older adults. So with that, thank you for the opportunity to share this with you, and really look forward to your questions and comments. And welcome back, Kit.
Thank you, Wendy, and thank you, Kit. And our apologies to everyone for the technical issues, but as we know, even though we have the NBN, it ain't quite there yet. Look, covered some great stuff there, and like I said, I've been across the Validitron for a while now, and this ability to assess systems in a near real world environment, yet in a safe environment is critical. A couple of questions have popped up. One question in particular has come up from Matthew Cowley. I represent an existing software product that operates in the home care space. As an open API, can already service a little bit much of the functionality demonstrated here. We'd like to engage better with the clinical space to be part of the consideration mix when scoping and designing clinical community solutions. How can we utilize programs like this to improve our visibility and consideration? So I guess it's as a vendor, how do they put their hand up and how do they engage with the Validitron? Is there a process that we can help them get the steps through?
Yes, excellent question. So we're just starting down the journey of collaborating with vendors on this, and there's multiple ways that we can partner. One is in integrating your tools into the sandbox so that you can now start to experiment with your tool in that environment, and then potentially making that available for other researchers and people to use within the sandbox as well. So being kind of a supplier side of the sandbox. Another way is to, as a partnership in the more design and validation side of, doing a project together. I wonder, Kit, if you want to say any more about either of those.
No, I think you've covered it off well. I think we're certainly open to both, and I think we very much want to meet people where they're at in terms of their appetite for either or both options.
So I guess one of the issues there, of course, raises is development of solutions, commercialization of solutions, marketing and sales of solutions. I mean, obviously, you see yourselves in that development and research component. Is there a process where people can utilize data from the Validitron as part of their ongoing commercialization and marketing perspective, or is that an area that is still being explored?
Well, it's still being explored because we're in early days for this. But we're really open to all different models, and we're really keen to be helping the industry generate evidence for the effectiveness of the interventions within the environments that they're meant to be used. And so we see, maybe a new stream of clinical trial or, trial evaluations of digital health interventions that's analogous to the clinical trial program, where you're really going down that clear process of generating that evidence in real settings and de-risking and creating, the ingredients that are much more likely to be adopted and successful. So depending on where you're at in that stage of you already have something developed and now you want to integrate it or find healthcare partners, or you want to evaluate it, or you're at the very beginning of just, you have an idea and you're starting to design it and you want to co-design it with people, we are open to all different models of partnership.
Okay. Bit of a technical question people are asking. From a technology perspective, do you use a specific cloud provider or a number of cloud providers, or is it all in-house in your own data centers?
So yeah, I can answer that. So we run on AWS currently. We are exploring working more closely with Oracle, particularly given their acquisition recently in the health space. We actually use an agnostic technology platform, so we're based around Kubernetes, and so we aim to be portable across different clouds if there are constraints, because we recognize, for example, that some people may be very heavily invested in existing clouds.
Yep. I guess an extension of that, someone's asking around the mobile devices. Android, iPhone, both options are available for testing. There's no specific.
Yeah, I think from no surprises, I guess, from an equity point of view, we think it's really important to support both.
Does anyone still support the old Microsoft phone? I still like my old Microsoft phone, but we won't go there. Interoperability is the big discussion point we have in healthcare. So a lot of people have been talking about them being interoperable, but many years ago, we used to run the Integrating the Healthcare Enterprise Connect-a-thons, and I think HL7 ran something in Brisbane just fairly recently, but demonstrating real connectivity rather than just pseudo connectivity, just saying we can grab demographic data and fill a screen, but we can't actually do that. Where are you guys as far as being able to, one, allow separated vendors to demonstrate that, and B, tools and education that helps the healthcare community understand what interoperability really means and how they can actually deliver on it?
Yeah, thank you for the question. Wendy, I don't know if you want to tackle the education piece, but maybe I can tackle the technical side of it. Look, I think we are thinking hard, and we continue to evolve our thinking about what is the thing that we can do as a university centre that's most useful in this space. And I think where we're at currently is that actually enterprise integration is something that there are quite a lot of actors in the space who are either upskilling quickly or already doing things really quite well. So I think the way we see our value is really at the user end of things, I think, around things like workflow, around things like what are the consequences of that integration for the stakeholders in the environment. And from in terms of a technical point of view, then what does that mean? The sandbox, for example, has public endpoints, so we can bridge to existing technology integrations, and obviously there's potentially lots to work through on a specific use case. So we can bring, for example, existing integrations into the sim lab to do that usability testing. So we're trying not to tie ourselves too firmly down to exactly how those integrations are realized, recognizing that other players may be better placed to set those up in the first place.
Yeah, I would agree with that, and that we are seeing this as a partnership where we're working with those endpoints in the hospital or the aged care facility or the GP office to really help design that interoperability. And in some cases, they will understand a lot about how to do it. And it's really, how do you bring this new technology in? And we're partnering on that. In other cases, they may not have the expertise, and then can we bring that expertise to them and work together to also upskill them as we partner on that together. And so I think in the project space, that depends on the people that we're working with and the skills that they have. But we do bring expertise in Smart on Fire, and have Graham Grieve and Kit and a technical team that we're building out to really understand that space and help guide how to excel in it. In the education space, I think that this is going to be a really hot topic, as it is around the world, but in Australia in particular. And the ADHA has contracted with HL7 Australia and CSIRO and us to create fire education across Australia. And so in the next year, we'll be developing materials for that. And the sandbox will be part of the advanced class on fire. And so we see that as a powerful tool to help really educate people as well, including ourselves.
That's great to know. And that's probably something we could reach out to the aged care community about, because the adoption of fire is starting to pick up in aged care. But as we look at standards-based solutions, I mean, recommendation 68 requires it, and yet we're going at that. And interesting to work with ADHA, because we're doing a lot of work at the moment with ADHA around the promotion and utilization of My Health Record and understanding use cases. So we've discussed how the Validitron can help you validate an existing use case. What about the blue sky thinking? How developing new use cases? Is that something you can work on there? Is that something that students do, or is that something we can develop together? Because again, how we use My Health Record at the moment is fairly limited by the original model of pulling up documents. But going forward into the 21st century, there's a lot of chances for improved use cases. So.
Yeah, I think that having this environment to be able to visualize and try out different things quickly opens up new possibilities. Kit, you want to say a little more?
Yeah, and to make that concrete, I think we tried to show a little bit of that today. I think that because we have some control over how the sandbox is running, we can ideate and explore at the existing defined interface points like Smart on Fire or like fire integrations. But we can also say, well, let's explore something quickly where that doesn't even exist yet, like the concept of doing something in the waiting room. So I think that ability speaks to your point, George, about where's the blue sky, or how can we sort of push beyond the existing constraints, is something that we're trying to be able to support by having this environment that sits in a research setting.
So one of the metrics we're using now for star rating is the consumer experience. So better understanding of how consumers are experience their delivery of care services. And as we move to a digital first type strategy around engagement, improving the consumer experience and the clinician experience. I mean, yeah, I've always been beating the drum that it has to make sense for the clinicians as well. Is there programs in place to move beyond just the technical side to improving that consumer experience through iterative testing of solutions and fast adoption of new screens and methodologies?
Yeah, I think that's really what drives this. The technical is the enabler, but it's really about the experience of the clinician, the experience of the patient, and bringing them in from the very beginning to co-design and test out and try new things together. Anything to add to that, Kit?
Yeah, thank you. I think as we've alluded to throughout this talk, this is early days for us. I think we're trying to figure out what the right balance is on the spectrum of co-design all the way through to perhaps co-production, where you have members of the healthcare constituency or members of the community doing more than just advising. And I think it speaks to our dual role as perhaps both doing this and also offering things like training and education on it, that I think over time we hope to become advocates for what is the best, or what are the most useful strategies to think about for a given type of problem. So I think there's a watch this space, but we're definitely thinking about it.
Excellent. That's exciting.
And part of setting ourselves up to be good partners in that space is getting the right people to help us know what the best frameworks are. And so we have qualitative researchers, a human computer interaction researcher, and we'll eventually this year be looking for someone who is an expert in service design as well to help do that aspect of the work.
Fantastic. So putting on my medical educator hat, one of the challenges we often face is that young doctors starting their internship for the very first time actually get to see clinical record systems. I mean, they touch them briefly during their undergraduate or postgraduate training, but they're usually in a very controlled environment and they don't have full access. Is there opportunities here for clinicians in that time when it's not being used for research to utilize the Validitron to try be it Epic or Cerner or any of the large clinical systems out there, play with it without breaking it? Because I mean, you break it in a hospital, you sort of that can be a career limiting step.
That's a great question. I know that for the last few years in the education materials that I've been developing and that we've been developing at the center, we have created some use cases that leverage different types of EMRs and data within EMRs to help clinicians, learning clinicians, but also budding informaticists think about the way EMRs work and the way data are messy, and the how to integrate and use decision support and those kinds of things. So I think we're passionate about that space. In the Validitron right now, we have kind of a shell of a program that doesn't really have any data in it. And that's always so that's something that we'll be working on. There are training EMRs that we have access to, like Teamer, the teaching EMR from Regan Street, which does have data, real data from hundreds of thousands of patients from Indiana. That's US data. There's a system that University of Queensland has developed with CSIRO that's being used in medical education and nursing education, and we're adapting that as well at University of Melbourne in nursing education. That's a case-based learning system that mimics an EMR, and you can elicit and input information in it and build Smart on Fire apps on top of it. So I think there are lots of possibilities, and the way that Kit's developing the sandbox, you could wrap these things into them quite easily, and maybe I'll let Kit say a little more about that.
I don't think I have anything to add, but yeah, thanks.
Sure. So call out then to our sector. So obviously the aged care sector is going through a lot of change at the moment. There's been a lot of implementation of new processes and procedures. So we've got the significant incident reporting in home care. We've got ANAC for funding in aged care. How can we get into the Validitron with a model for around aged care, both residential and home care? Because what you focused on today was about some of those home care clinical solutions, but on a larger scale, how does the aged care industry engage more effectively with you guys to validate some of the solutions we have in place. But as Anne would tell you, in our last report, we found over 400 applications being used in aged care. We had some very serious questions about how effectively they were being used. So how does either the council or the aged care industry in general engage with you? And like I said, happy to facilitate that discussion going forward into next year.
Yeah, I'd love to have that conversation. And I think the hardest part of it is really choosing what to work on. Out of all of those choices, what are the most promising? But that's part of the work I think that the Validatron hopes to provide with insight reports is how to make those decisions about what the most promising applications of the future are, and then so love to go down that pathway with you, George.
Cool. We'll continue that discussion. And I don't know if you've been engaged, but Faye Flavaris has been running a number of co-design workshops through the Department of Health recently, looking at some of the more B2G side of things. So as we move on from that, I'm happy to we'll arrange some further discussions. Look, unless there's any further questions or anything else you'd like to add, Wendy or Kit, I'll move on to the closing for the day.
No, thank you so much.
Yeah, thank you.
No, well, look, first of all, thank you both for your great presentations and for the demonstrating that technology requires two people to collaborate to make sure we get the right message across. That worked out really well. The presentation has been recorded, so it will be made available for those of you who want to watch it again or pass it on to friends and colleagues. It is critical that we do validate what we're doing in this space. So having been in digital health for some 30 or 40 years, we've moved past that hype cycle of describing everything as a revolutionary solution, and we now need real evidence. And things like the Validatron, I think, are a great example of how we can do that in a safe, controlled way, and build on that whole learning concept. So learning healthcare, learning aged care, learning care is a critical component. So thank you both Kit and Wendy for that. Our next research webinar will be after the Christmas and New Year break. So we have our next research webinar will be on the 31st of January 2023. I've got to start getting used to that now. With Flinders University, and will be followed by one with the University of Technology in Sydney on the 23rd of February. If you want to attend those, keep an eye out for postings on LinkedIn or our emails that come out regularly. We will be communicating with that. We are taking a short break over the Christmas New Year period, so if we don't respond to you as quickly as you're used to, except our early apologies, but come mid-January we will be back in force. On behalf of the council, I'd like to thank you all for collaborating with us in 2022. It's been an amazing year. We've had a lot happen in aged care, following on from the Royal Commission report and the implementation of many of those projects. We've seen the Australian Digital Health Agency launch a specific aged care focused group. We've seen a lot of activity. So 2022 has been a busy year, but it looks like 2023 is going to be bigger and better. And look forward to working with all of you in 2023 to improve the quality of care for older Australians and their families. Our contact details are on the screen there. We can be contacted by email. Like I said, we may not respond quite as quickly over Christmas, but we will respond. We also do have a fairly active LinkedIn group on LinkedIn. So if you look up Aged Care IT Council, you can find us on LinkedIn. We look forward to continuing discussions. Thank you again for our speakers, and thank you everyone for attending, and all the best for the festive season. Goodbye.